Sir, myself.
Good morning, everyone. Good morning, everyone. Amit will be presenting the case. It will be moderated by Professor Venkatrami Reddy, Professor T.D. Yadav, and Professor Parthasarathy. It's all yours. Now you can take over now.
Yes, sir. Thank you. Yeah.
Good morning, sir. Am I audible, sir?
Yeah, you're audible.
Yeah, I'll be starting today's case, sir. This is a case regarding 47-year-old gentleman, a businessman by occupation, resident of West Bengal, presented with chief complaints of yellowish discoloration of eyes and urine since 1 month. Coming to history of the apparently normal 1 month back, when he noticed yellowish discoloration of eyes and urine, gradually progressive, painless in nature, it was associated with intermittent generalized itching, not associated with sleep disturbance since 1 week. History of intermittent low-grade fever, relieved on oral medication, not associated with chills. History of passage of pale-colored stool since 2 weeks. There is history of unintentional weight loss of 5 kilos in 1 month and loss of appetite is present. There is no history of abdominal pain. Coming to the negative history, patient is having no history of vomiting. I wanted to know whether there is early satiety or postprandial fullness. There is no history of waxing and waning of jaundice or silvery stools. There is no history of altered bowel habits, but there is history of pale colored stool in the history of presenting illness. There is no history of hematemesis, melena, postural dizziness, syncope, fatigue, shortness of breath, or need for any blood transfusion. There is no respiratory discomfort, hemoptysis, bone pain, or backache. No history of drug abuse or alternative medication intake, or I wanted to know regarding high-risk behavior. There are no history of any prodromal symptoms. There is no history of any recent onset diabetes. I would also like to know regarding history of endoscopic biliary intervention, if any. Coming to past history, there is no known medical comorbidities. There is no history of any surgery in the past. I would like to have know regarding a history of similar complaints in the past, sir. There is no significant family history. Coming to personal history, sleep is normal, appetite is reduced, bowel and bladder habits are normal and regular. He consumes a mixed diet and there is no addictions. Should I summarize, sir?
Yeah. Can you go back to the slides, what you wanted to know?
Sir. So coming to this next. Sir.
Recording in progress.
Yeah.
Sir.
Okay, next slide you can go.
Sir, I wanted to know regarding early satiety associated with vomiting and postprandial fullness to rule out any symptoms of gastric outlet obstruction.
Yeah, and so he didn't have any such symptoms, I think. No vomiting, no physical for gastric outlet obstruction then.
Sir, and there is a mention of no history of altered bowel habits, but on history of presenting illness, there is pale colored stool. So yeah, I would like to have corrected this.
Yeah, but passing pale colored stool doesn't mean that there is alteration of bowel habits. So alteration of bowel habits is totally a different thing, no? It's not pale colored stools he can have, but still have normal bowel habits. That's a different issue. Okay.
Sir.
Yeah. What do you mean by silvery stools? They said there is no evidence of silvery stools.
So silvery stool signifies the basically periampullary malignancy. In this, there is sloughing of tumor cells along with mixture of blood. So it gives a silvery color to the stool, sir.
So it says that there is some evidence of GI bleed. Okay.
GI bleed, sir.
Yeah. Okay. Then what else you wanted? High risk behavior. What do you mean by that?
Sir, I wanted to know regarding any history of any HIV infection or any history of HBsAg positivity regarding this patient, because these things can lead to cholangiopathy in this patient, sir. HIV related or hepatitis related cholangiopathy.
Any prior history you wanted to know?
Sir.
Yeah, I think he doesn't have any such history. Okay.
Okay.
Yeah.
And also, sir, I would like to have known regarding any, because patient is having jaundice, any similar endoscopic biliary procedure, biliary intervention done prior to this thing. Would have given a better idea, sir. If
probably.
Been there.
If it would have been there, they would have mentioned, I think, probably. So it's not there.
Sir.
Yeah.
How common is respiratory discomfort and hemoptysis? What did you ask that history for?
So this thing is regarding if I suspect a metastasis in case of malignancy, sir, there would be pleural effusion or lung nodules along with which can lead to respiratory discomfort and hemoptysis, sir.
So trying to rule out the metastatic disease.
If like I'm suspecting a malignancy in this case, sir, so I would definitely like to rule out a metastasis.
TD, sir. Good morning, sir.
Morning, good morning. Yes, no, most of the points you have already asked, but actually, what Dr. Partha is making a point. Why you are suspecting metastasis in 1 month history? Any significant point which is suggesting toward the metastasis, and that too, your pleural effusion is the commonest thing?
No, sir.
And all those things, or any other way of metastasis might not produce any symptom.
Sir.
Am I audible?
Sir, your voice is low, sir. TD, sir.
My voice is low.
Yes, sir.
Okay. So is it better now? No.
Yeah, I think we can hear you. No?
Yeah, yes, sir.
Yes, sir.
Yes. Dr. Amit, are you able to hear me?
Yes, sir. Now I am able to hear you, sir.
So the question is same what Dr. Partha said. So is it you are saying that pleural effusion, is it what is the commonest way of mode of respiratory fetal you are suspecting in a chest?
Sir, it would be like to liver and peritoneum, sir.
No, I'm talking about chest.
Commonest mode would be, sir, by a blood vessel, sir.
So I don't understand many of your points. Like what is high risk behavior you have made highlighted in the red point?
Sir, if any active sexual history is there with multiple sex partners, so that would highlight a risk regarding HIV infection or hepatitis. So that will lead to a diagnosis regarding either a medical cause or surgical cause.
So is it the way in 1 month history all this presentation would be there? You have already said only 5 kg weight loss is there, and other symptomatology regarding the same.
Sir, very less likely, sir.
No, there would be many things to have a jaundice, but you have to have a clear-cut thinking process, and that should make any relevance in assisting your diagnosis or excluding whatever you are thinking. So if you are thinking about HIV, hepatitis C related things, is it a common way of presenting like the way it has presented the patient?
No, sir.
1 month history, painless progressive jaundice of 1 month.
No, sir, it won't.
So, yeah, you have already mentioned prior history that is already been discussed. So when we go about what would be your thinking process?
Yeah,
sir,
you can summarize now and yeah, you can summarize. Go to the next slide.
So coming to my summary, a 47-year-old gentleman resident from West Bengal, having no known comorbidities, presented with 1 month history of painless progressive jaundice, which was associated with passage of clay-colored stool since for 2 weeks, and generalized itching for 1 week, with history of intermittent low-grade fever relieved on oral medication, associated with loss of appetite and unintentional weight loss of 5 kilos in 1 month. So at this point, I would like to think regarding extrahepatic origin, most like of obstructive jaundice, and most likely malignancy, because patient is having weight loss and loss of appetite associated with painless progressive jaundice with passage of clay colored stool and generalized itching. My first differential diagnosis in as per history would be hilar cholangiocarcinoma, sir, followed by CAGB, likely neck, and followed by periampullary malignancy. And on lower down, I would like to keep CA head pancreas.
Okay. How do you substantiate your order? What you have kept? Like first, why hilar cholangio?
So the patient is having classic symptoms of hilar cholangio like painless progress, but there is no history of any preceding jaundice, preceding itching prior to jaundice. That is one point which is against. And apart from that, the signs of malignancies are there, like weight loss and loss of appetite is there. So I would like to consider hilar cholangioma as the first differential diagnosis. And considering the patient is from West Bengal and age group near about 50, so I would like to also keep CAGB neck as my second diagnosis.
No, Amit. The question is, we have all, you put all the malignancies, malignant obstructive jaundice as a differential diagnosis. The question is,
Sir.
What is the point which puts hilar cholangiocarcinoma above CAGB neck and periampullary carcinoma?
Yeah, or even your CA head of pancreas. Yeah.
Sir, at this point it is difficult to tell, but because the history, on the basis of history, it is a painless jaundice.
No, we all have agreed on the malignant causes that you have given list. You just have to justify the reason behind ordering them this particular way. So there has to be one or 2 points which puts hilar cholangio as your first diagnosis, and a point why CA head of pancreas is down the list.
Sir, at this point, sir, this is mostly painless, sir. Painless jaundice is keeping it prior to rest of the causes.
So painless jaundice, hilar cholangiocarcinoma, there was a history of fever also. He has taken.
There is one.
So you can get even periampullary also painless jaundice, ampullary malignancy also. Yeah.
Right, sir.
Even early pancreatic head malignancy also can be painless.
Sir.
So if you don't have anything specific, then how do you put the order? Like more like the commonest thing first, like that, or?
No, sir. According to pain, I have kept. Commonest thing here would be like at this region would be CAGB neck followed by periampullary carcinoma.
But CAGB neck would have had some pain because of distended gallbladder. Patient would have had some pain to have been there. Okay.
Initial stages might be, sir, having only painless. It might present like painless, sir. Initial stages.
What percent of the gallbladder cancer will produce will be having jaundice without pain? It's not philosophical. Can you tell that this percent of the CA gallbladder people will not have pain when presenting as a gallbladder cancer?
Sir, based in geography, sir, I have kept CAGB here.
You are not talking in a theory exam. Here is a patient. You are giving your differential diagnosis. So give the relevant point that this, because of this percent would have pain, I am keeping this as a diagnosis. And this patient also had fever. Was he can taking maybe oral medication. There is no clear-cut mention of what type of medication he has taken. You have not tried to look into how many days that had you mentioned in your history that I want to know how many days that particular medication was taken, but it is only that he took some medication. We don't know what medication he has taken. So my query will be what percent of the higher block would present with the fever, and as you said, painless jaundice is one important point. But what about fever?
Sir, less than 10% will present with cholangitis symptoms, sir, fever and all of hilar malignancy, sir.
So fever would be more common in distal or proximal tumor?
Sir, more common in the distal tumors, sir. Lower down, sir.
Okay. So still you can substantiate your order?
So you have the way we talk in a clinical medicine that our points favoring the diagnosis should be more than the negative points. You should only one point that which is the painless jaundice. Then you said that immediately you countered your own diagnosis by saying that the pruritus was not preceding the jaundice. It is 100% mandatory that pruritus should precede jaundice in hilar cholangio.
No, sir.
So the way to in the exam that when you are keeping your first diagnosis, you should have few points more favoring the diagnosis and lesser points should be against the diagnosis. Like 5 points, 6 points, you are in the favor of diagnosis, 2 points might be against your diagnosis in a clinical medicine. But once you have only 1 point in favoring which is diagnosis, pale jaundice, but at the same time, and if I am asking what about fever, then you are saying less than 1% would present like a fever. Then you are saying pruritus, again, pruritus is precedes, but it's not 100% that pruritus will always precede the jaundice in a higher level. So your own differential, you are not able to clear cut have an idea that how should I defend my first diagnosis. That is the problem. Same way, okay, Dr. Partha.
Yes, sir. Yeah. You don't have any strong points to say this, or if you don't have points, you can tell them actually that I don't have a very strong point to support one diagnosis over the other, but these are the different diagnoses I have to consider. You need not unusually magnify a small point and use it as a defense for your order.
Okay, and we can go ahead with the examination.
Said second CA carcinoma gallbladder, you kept at a second point. But you should have read yesterday when you are so much your thinking process is so much about geography and epidemiology that in northern and India and eastern India, commonest cause of surgical obstructive jaundice is carcinoma gallbladder. Then you should have gone and read it that what percent would have no pain, what percent can present with the fever. These are the very important relevant points. Then only it makes a good sense of presentation. Then if I ask you why peri-ampulary at the third, what are the points by which you can say that this peri-ampulary carcinoma is my third diagnosis?
Sir, patient is not an elderly, is a middle-aged person, and also there is history of a few episodes of fever, sir. So I would like there might be some lower end obstruction in this case. So I'd like to keep peri-ampulary carcinoma lower down the order, sir.
How are you justifying? Same thing you are repeating. Peri-ampulary coming on third point. That is fever is favoring peri-ampulary or not favoring? Let me ask the direct question. Intermittent fever is what talking about. We don't have any idea. You should have asked, made the red point that I want to know about the fever, more detail, how many days the medicine was taken, then would have made a sense. You have only low-grade intermittent fever, but you tell me why peri-ampulary carcinoma should not be the first diagnosis.
So there is no waxing and waning of the course. Neither there is history of any silvery stools, sir.
So peri-ampulary, which particular type of peri-ampulary will have waxing, waning, jaundice, and a silvery stool?
Sir, ampullary type, sir.
Ampullary type. What percent of the peri-ampulary would have ampullary type of cancer?
Less number, sir. Less exactly.
I think you should do yesterday in the evening when you are preparing your case that these are the points I would justify or not able to justify. So it becomes very vague. Only one component of a lower block has this thing, but you people, I am seeing in every presentation, you talk of that component, which is very small component of the peri-ampulary carcinoma. Lower cholangio is a part of peri-ampulary or no?
Yes, sir.
Can it have waxing and waning jaundice?
No, sir.
Then ductal adenocarcinoma is a part of peri-ampulary?
Yes, sir.
Can it have a waxing and waning jaundice and silvery stool?
No, sir.
So that's why I'm saying your exercise, you people don't try to analyze your history, that these are the points I will present and try to defend when I am presenting my case in front of my whatever faculties are there. Yes, Dr. Partha, any other point or we can go to exam?
We can proceed, sir.
Yeah, yes. Examination, sir, you can proceed.
So coming to general physical examination, patient was conscious, cooperative, and oriented to time, place, and person. having a BMI of 24.2 kilogram per meter square, moderately built and well nourished, ECOG score of 0, breath holding time was 35 seconds. On examination, icterus was present. There was no pallor, cyanosis, clubbing, lymphadenopathy, or edema. Vitals were normal. There was no enlarged supraclavicular lymph nodes. There was, I would like to know regarding signs of liver cell failure. On abdominal examination, flat and umbilicus was central in position and inverted. All quadrants move equally, move correspondingly with the respiration. No visible scars, peristalsis, sinus, or engorged veins. There was scratch marks were present. Hernial orifices and external genitalia appear normal. Bilateral renal angle appears normal. On palpation, patient abdomen is soft and non-tender. Liver and spleen are not palpable. Gallbladder is not palpable. And hernial orifices and external genitalia are no, there is no palpable impulse. Coming to percussion, liver dullness, upper border is palpable at 5th intercostal space in the right midclavicular line. Liver span is 13 centimeter in right midclavicular line. Flanks are tympanic. Auscultation, normal bowel sounds are heard. On digital rectal examination, normal sphincter tone was there, and glove was stained with pale colored stools. No palpable growth or pelvic deposits were felt. Respiratory system, there was no vesicular breath sounds. It was essentially normal. CVS and CNS are essentially normal. Coming to my summary at the end of examination, sir. Should I proceed, sir?
Yeah,
Yes.
go ahead. Anything clinically? You got any additional information?
So clinically, sir, there were icterus on examination, and on examination on abdominal findings, sir, the gallbladder was not palpable, sir.
Yeah. No hepatosplenomegaly also.
No organomegaly was there, and on DRE, we had clay colored stool where glove stained clay colored stool is present, sir. Coming to summary, 47-year-old gentleman, resident from West Bengal, having no known comorbidities and ECOG score of 0, presented with 1 month history of painless progressive jaundice, which was associated with passage of clay-colored stool for 2 weeks. And
the summary. Summary should be 2 lines maximum. Already one you have summarized one. So just can you tell me that what extra, how your sequence, what you have mentioned in the differential, how your examination has been able to add to your differential, or you have been able to exclude something because your sequence again is the same.
Sir, right, sir. My sequence would remain the same because examination finding, we had findings of non-palpable gallbladder. So I would like to still consider hilar cholangio higher up in the order because GB is not palpable in this case. And I would like to keep CAG neck along with hilar cholangiocarcinoma next in the on the list, and followed by less likelihood of periampullary carcinoma and C head of pancreas in this case.
My immediate question would be, what percent of the distended gallbladder would be palpable clinically in a patient with BMI is 26?
Sir, last line is not audible.
Sir. In a patient where BMI you have mentioned 26, so what percent of these people will have palpable gallbladder when it is distended?
Considering the patient is having a good BMI, sir, 50%, sir, approx.
50% still won't have a palpable gallbladder. So you can say that my gallbladder is not palpable, but it cannot be 100% gospel proof that, oh, since gallbladder is not palpable, I am excluding. Then you said in the same sequence, I am taking the CA neck of the gallbladder as a differential because gallbladder is not palpable. Gallbladder in CA neck will be palpable or not palpable?
CA neck will be palpable, sir, but I would like to consider early stage involvement, so there might be.
To say gallbladder cancer presenting with jaundice is an early gallbladder cancer. My dear, don't give so contradictory statements. That's why I said exercise. You people don't do properly, don't drill when you are preparing the case. So you think in all over in the country we are not able to operate so many patients of gallbladder cancer when they are presenting with the jaundice. So your both statements are contradictory. Here is a patient who is presenting with obstructive jaundice, and you are saying that gallbladder is not palpable, but I am considering it as a, because it is a early gallbladder cancer.
Can you substantiate in a different way, CAGB, if at all you want to put it, than putting it the neck of GB?
That the Venkatrami comment they give, that gives a very important point that
Yes, sir.
for understanding of that particular subject. Please don't
Yes.
give comments which are make your point so much negative. Whatever
Yes.
this is very important in the exam. That our statement should be very thought process should be very accurate.
Yes.
Don't give any so much thought process that examiner gets a point that, oh, you have no idea of the that particular disease process. Yes, Dr. Partha.
Why did you check for hepatosplenomegaly?
Sir, in jaundice, there will be hepatomegaly, sir, and if there is any portal vein involvement or something, then there might be splenomegaly, sir, as well, sir.
Is there much more commoner causes for splenomegaly than portal vein involvement? In a malignancy which has involved the portal vein, is it common to see splenomegaly? 1 month history?
No, sir, less likely, sir.
Okay. Any other more common causes for a palpable spleen?
Don't know, sir.
Cholangitis can cause spleen enlargement.
Sir.
Subclinical cholangitis
Yes,
can only with splenomegaly.
sir.
One more very important nowadays point I think we must discuss in this patient. This patient, you are saying he's very well nourished and his BMI is 26, that's why. So is it only BMI is the very important thing to have to assess the nourishment, or there are other factors which are more relevant, which add to the your assessment of the nutrition?
Sir, apart from BMI, skin fold thickness and albumin level, all these things help in assessing the nutritional status.
Go worried into any of the nutritional risk assessment or nutritional screening?
Nutritional assessment screening is there, sir.
What are the important things you know about that? 5 kg weight loss in 1 month. Do you think it's add to the nutrition or it's irrelevant?
Sir, it is an unintentional weight loss, so it is quite relevant. 5 kilos is a significant amount, sir, in 1 month, sir.
Can you name any of the nutritional risk you know you are using in your institute? Nowadays, it's very important, coming in every field, including colorectal cancer, any of the malignancy, even head and neck cancer.
We have not been using, sir.
Oh, okay. You know what? Are you aware of subjective global assessment? So suppose the patient comes with pedal edema and with the BMI of 26, would you consider it a very good malnutrition?
No, sir. It is
My
a faulty BMI.
points are now at this stage, now in the today's era when you are appearing for the exams, you must know all these things. Yes, Dr. Venkat, Dr. Partha, please.
Yeah.
We can proceed.
Yeah, you can proceed, sir. Yeah, how will you proceed now with this patient?
So consulting my diagnosis, I would like to first know regarding the CBC, LFT, and RFT of this patient, sir. Renal function.
So for your diagnosis information,
Can you just say what is your full complete diagnosis?
So my diagnosis, sir, it is a case of extrahepatic biliary obstruction, most likely due to malignant etiology, and I would like to keep hilar cholangiocarcinoma as my primary diagnosis in this case.
That's all. Anything you want to add? Yes, patient also has some cholangitis, no?
with subclinical cholangitis, sir.
Why subclinical? He has obvious fever and all that.
This is why you are saying subclinical. He has received oral medication. So in
Yes.
a total guidelines, does it come in any of the component of cholangitis, or it is subclinical according?
Sir, patient is having low grade fever with which was addressed with oral medication, sir. So, and there was no associated chills or rigors.
Guidelines, is it fitting into cholangitis or not?
It's fitting into cholangitis.
Which company? There are some classifications.
The typical features of cholangitis: pain, fever, and jaundice, sir. Pain, the jaundice and fever is there.
You are trying to dodge the question and go around, beating around the bush. The question is very simple. Intermittent low-grade fever, he received oral medication. According to our accepted guidelines, is it fitting in cholangitis? And if at all, then which classification? There is a classification, you must have read that. Don't say that I don't know about the classification of the cholangitis.
So, Tokyo grading is there, sir.
Okay, then go ahead. I thought, then
Yeah. So, because we don't know whether he received only antipyretics or even antibiotics, we are not sure. No, they just said only oral medications. So we don't know. Maybe he must have used even antibiotics. We are not sure. Okay. Fine. Okay. Word with what you want now. How to evaluate this patient?
I would like to know the blood investigation reports initial, CBC, LFT, and kidney function test.
Anything else? You want to just tell complete what and all you want.
Yeah, Dr. Venkat, I was going to say the same. In exams, you go very this thing, like I will do this.
Yeah.
So suspecting malignancy, I would like to know along with associated cholangitis, I would like to know the CBC along with LFT and also the RFT, because I would like to consider imaging for this patient and also like to know the AKI status, if any. And followed by that, I would like to know the tumor marker status of CA19.
What about other things? Like you were suspecting any, some history you were asking, no?
Viral markers, sir.
High risk you were talking about. You're not interested to know that?
Yes, sir. Viral marker I would like to know.
And then anything? Coagulation you don't want to know?
Sir, coagulation profile, of course, sir. With
That's what you tell all what you want, no? The basic things you have to complete in one go and... Okay.
Sir.
Fine.
So the hemoglobin is 10, total count is 10,000 and platelets are 3.4, which is adequate. So patient is presently not in any cholangitis, having a count less than 12,000. So I would consider patient having a normal total count. That's it, sir.
My assessment it is toward the higher side. I would like to have the subdivision of the total leukocyte.
Neutrophil count, sir. Yeah. Neutrophil percentage.
Adding to my comments is not going to add to any point in your exam. Your comments are very important. What you say, like you say AKI. Where is the AKI in the history of this question? So randomly using the terminology is a very dangerous in exam. Please remember, this presentation is basically to prepare you for the exams also. What next you want?
So because of jaundice, there might be dehydration and there might be prerenal. So I would like to know the creatinine and urea, sir.
Rather than before that, there might be dehydration, there might be starvation. Please avoid. You are not even bothering to listen. Please give. I want to know the creatinine level, serum creatinine, serum urea. Rather than saying because there may be a dehydration, I am thinking about a creatinine. If there is no dehydration, you will not do creatinine. You say that I want to assess the kidney function test. Please show the kidney function test.
Yeah.
The blood urea is 29 and creatinine is less than 1, that is 0.99. So it is normal. Patient is having hyponatremia of 126. Potassium is in the normal is 5 and chloride is near normal 93. So.
Okay. Liver function test? Yeah.
So patient is having total bilirubin of 12.2 and with a direct fraction of 6.9 with 2 to 3 times raising of transaminases and along with the alkaline phosphatase. And albumin is 3.6 with INR of PTINR of 10.9 and 0.92. So my inference is a direct bilirubin with mild elevation of transaminases with elevation of alkaline transaminases along with having a normal albumin level of 3.6 with a normal functional liver with having INR of 0.92.
Dr. Amit, what is the interpretation of this particular liver function?
Sir, I am suspecting obstructive jaundice in this case because
No, not suspecting. We already have made a diagnosis.
sir, this is the case of obstructive jaundice. I can see the direct fraction being more is 6.9 out of the 12.2, along with but the synthetic functions are normal of INR being 0.92, sir, with mild raising of transaminases up to 2 to 3 times.
Again, reading. I am asking you what is the interpretation of this?
Yeah. How do you interpret your enzymes? How do you interpret your
the enzymes, sir? The enzymes are 2 to 3 times raised. So I am suspecting.
What do you interpret from that?
Sir, patient is having a mild cholangitis at this stage, might be due to sir, and albumin is slightly is not near normal. It is above 3.5, but is on the lower side, sir.
So it's an obstructive jaundice, some amount of cholangitis, probably. Okay.
Sir.
Next. Viral markers probably negative. Okay. Okay. Anything else you want? You wanted CA99.
CA99, sir. I would have seen, sir. Sir, CA99 is elevated is 1007.9, sir. So it can be elevated, sir, in case of obstructive jaundice. So it is not very conclusive, but still, if it is quite high, I feel.
Do you have any idea of corrected value of CA99?
Yes, sir. It is the value of CA99 divided by the direct fraction, sir, of total bilirubin, sir, of direct bilirubin.
What is now then? If you correct it, then what is the level of the CA99?
7. If I would like to divide it by 7, still the value would be above 37, sir. So still it will point towards more likely a malignant cause.
1000 you divide by 7, it is only 37.
Above 37, sir.
Above 37, that's all.
See, you have a significant level. Even
very significant, sir. Above 100, sir. So.
Okay. Fine. Okay. So next, what do you want?
So next, I would like to see the ultrasound report, sir, in this patient.
Amit, in a patient with obstructive jaundice, you said you'll check for creatinine, and the reason you gave was patient can have dehydration and acute kidney injury. Is that the common mechanism for raised creatinine in obstructive jaundice patient? And why would they have dehydration? Is he vomiting?
No, sir.
No. So why, first of all, why dehydration? Second, is that the reason for finding high creatinine in an obstructive jaundice patient? Do we see high creatinine, elevated creatinine in deep obstructive jaundice?
No, sir. No, sir.
No?
Mostly if there is cholangitis, then we can suspect, sir. But only jaundice, there is less likely that creatinine will be raised.
Only jaundice does not affect the kidney?
It will affect the kidney, sir.
In what way?
By deposition in the glomerulus membrane, it might cause kidney injuries, sir, acute kidney injuries.
So dehydration is not the cause. Okay,
yeah.
Not the first cause.
Yeah, you to know all the causes for pathophysiology, no? It's very important, pathophysiology. Okay.
Very important point Partha has raised. And Dr. Amit, you must know that obstructive jaundice and the kidney is a very important factor. If you any textbook you are reading, maybe Bloom, but we see how many pages they have mentioned about obstructive jaundice and kidney, what are the different mediators which produce, how blood circulation is diverted from that one particular area to another, and that's why there is a relative type of thing So many things. I think we cannot teach kidney, but we will definitely advise you to go today only and read obstructive jaundice at kidney, because the answer you are giving, it suggests that you have not tried to look into all these factors of the obstructive jaundice, how kidney is getting affected, and what precaution you must take when you are preparing a patient of the surgical obstructive jaundice.
Yeah. What next you want? Now we have got the blood investigations. Next.
Sir, I would like to see the ultrasound report, sir.
Yeah.
Sir, on ultrasonography of the abdomen, liver is normal in size and normal nicotexture. There is mild bilobar ISBRT is noted. CBD appears dilated with abrupt tapering in the distal CBD. The gallbladder is distended. There is no calculi, and spleen and pancreas normal, sir. Pancreas bulky head with ill-defined hypoechoic lesion causing upstream ductal dilatation. MPD measures 5 mm in the body and tail. No interductal calculi or parenchymal calcification is noted, sir. My inference in this case would be like lower down. There is mild bilobar IHBRD, but there is no peripheral IHBR. So maybe in the initial stages, and there is a distended gallbladder and with a bulky head lesion in the pancreas. So my diagnosis here would be like.
Did they give you that point anywhere which you inferred now? That there is no peripheral IHBRD, only central IHBRD. Is it mentioned anywhere?
No, sir.
Then why did you say
Bilobar,
that? It's a bilobar, you don't know. Okay.
More important, Dr. Venkat, I would like Dr. Amit, you see whatever you made only two important points to say that even after examination, gallbladder is distended. You will see gallbladder is distended.
Yes, sir.
Said that there is cannot be hilar cholangio. You did not want to consider anything. Here is a patient who is having lower down obstruction. By the same logic that there is a intermittent cholangitis, there is a patient with obstructive jaundice with progress. Intermittent cholangitis is commoner, more common than CA head and hilar in a periampullary tumor, because of the simple fact that there may be ascending cholangitis from the ampulla ascending to the this thing because of the some sort of region getting sloughed out or whatever is the reason. Gallbladder cancer again, it can produce fever because of the simple pathophysiology that it most of the time stone is the cause and bile is infected. So that is very, very important that only one point you catch and try to explain everything and base everything on your one point is not good at all. So you must have a broad mind, broader thinking, and multiple points you should consider when you are talking about making a differential diagnosis. Because obstructive jaundice, every exam it will be present. So go ahead.
And there is a bulky head lesion with hypoechoic lesion in the pancreas, and MPD measures 5 mm. There is no evidence of any prefluid in the abdomen, or there is no soil in the liver. So I would consider pancreatic etiology most likely C head of pancreas in this case, on the basis of USG.
Still, why you are adding most likely? Why you are so fond of adding adjectives? Here is one good ultrasound.
It's a case.
So
it's a case of C head of pancreas.
Yeah. Okay.
What next you want to do now?
Sir, the first point is that there is a case of obstructive jaundice with bilobar IHBR, followed by lower down obstruction because the gallbladder is distended, and there is a bulky lesion in the pancreas.
Sir, what do you want to do next? You tell and then substantiate why you want to do, because.
Sir, I would like to know. I would like to do a CCT triple phase in this case, sir. With pancreatic protocol. Pancreatic protocol.
What do you want to do? Triple phase or pancreatic protocol?
Pancreatic protocols.
Both are different?
Yes, sir.
They're different, no?
Are they same or different? And if different, what is different in the pancreatic protocol?
So the slices are thin in case of pancreatic protocol. 2 mm size slices are there.
Is it only the slice or something else is different in pancreatic protocol?
How many phases you have in pancreatic protocol?
Sir, non-contrast phase and arterial phase, late arterial phase, and portovenous phase.
Okay. So late arterial is also called as what?
Early pancreatic phase. Pancreatic phase.
What is early then? What is early arterial phase?
Pardon, sir?
What is early arterial phase?
So early arterial phase is from 15 to 20 second post contrast injection, sir.
What does it show? Why it is there?
Sir, it enlightens mostly the vascular system, sir, the aorta and the arteries, sir.
Anything else? Okay, you can see the arterial anatomy. Anything else? Anything pancreatic pathology you can differentiate?
Any arterial anomalies, sir, in this case, aberrant anatomy, arterial system, sir.
Dr. Venkat is asking something more. You have told arterial anatomy, artery will be shown. What Dr. Venkat is trying to say, what are the other things which can be seen on the artery?
Sir, any pseudoaneurysms? Any
What are the arteries?
sir, or sir, not audible, sir. Pardon, sir?
No.
What I'm saying, whatever you are describing, that is part of the arterial anatomy only.
Sir.
Dr. Venkat is saying anything else which can you see on the early arterial?
So arterial, you can see anything, no? Any hypervascular tumors like neuroendocrine?
NETs and all we can.
That's important, no? Okay.
Sir.
Okay, so what do you see in pancreatic adenocarcinoma then?
Sir, hypodense lesion in the artery in the pancreatic phase, sir. In the late arterial phase, sir.
It's a parenchymal phase, okay.
In the pancreatic phase.
So, okay. Yeah, so you should know actually what is the exact timing that you do in pancreatic protocol and also the triphagic CT. Okay, how much contrast is given, all that should be known. Okay. Yeah, can we have the CT films?
Can I have the controls? Yeah. This is the arterial phase, sir. Not able to move. So on this image, I'll go. The lungs, bilateral lung fields appear normal. There is no effusion, no nodules. The liver appears that ISBR can be noted. This is a portovenous phase, sir.
Why you are going to portal venous phase first? Go in a sequence the way you told.
Sir,
yeah, I think, yeah. They have these films only, I think. Okay, go ahead.
The liver appears normal. There is no SOL as such. The GB appears distended. The CBD appears dilated. there is.
At least when you are speaking, we are not able to see the same thing. You can show the picture and go ahead. Is it a very good arterial picture?
No, sir.
Go ahead and start from the above rather than coming so lower down. And you can describe the structure rather than tapping gallbladder is not seen. When you are treating artery is not seen. So please go in the sequential manner.
IHBR can be noted, sir. The portal vein bifurcation is normal, and your gallbladder is distended. CBD is prominent, sir. MPD I cannot note at present. There is.
You have not come to that plane at all still.
The diode of ampulla appears normal. There is this thing I can note, sir. There's some hypodensities in this head and uncinate, sir.
How did you make out ampulla here? You said it's normal.
Sir, the duodenum, it seems like there's no.
Okay. Describe the tumor, what you are seeing. Go ahead.
There is a hypodense lesion, mostly also. This thing, sir.
Where?
This thing, sir.
Okay.
Hypodense lesion in the head of pancreas, sir. CVD is dilated and gallbladder is distended, sir. There is the liver, there is no SOL as such. There is no aside.
Tell about the tumor first.
Sir,
that point you have already mentioned, CVD dilated gallbladder distended.
Sir.
Yeah. Tumor characteristics and then.
Relation to vascular structures.
Yeah.
This is the splenic vein, portal vein.
My suggestion would be you go to the late portal vein phase. Let us see what is seen. That you are not able to describe the tumor very clearly. So,
in this thing also, there is no.
Don't repeat the same findings. Go to the relevant area and then.
can you see in a better way now? You are just in the early phase. You are describe everything. So the question is, as a registrar, you must go to the radiology department and try to see the picture, sit with your radiology friend and try to learn radiology.
Here we can see a hypodense lesion.
See, Amit, we already have found a lesion in the head of pancreas. You have moved to the next phase to comment basically on the vascular involvement.
The vascular portal veins appear normal, sir.
No. Is the region in relation to the portal vein or the SMV? Or both? Is it below the spinoportal confluence or above it?
It's above, sir.
It is superior to the spinoportal confluence or below the spinoportal confluence?
It is superior, sir.
Can you show the spinoportal confluence? Okay.
Yeah.
So you're finding the lesion at this level, or when you scroll down, you find the lesion?
Here, sir. Below, sir.
Below. So which vessel you are interested in now?
Sir, SMB, sir.
So can you quickly come to the SMV and comment on that?
Sir.
Is the lumen of SMV unaltered and seen untouched by the tumor, or is there a distortion?
SMB, sir, is distorted.
Is it contrast filling is uniform, or is there an area of non-contrast filled SMV?
So what do you look at the vessels when you're commenting on the vessels?
Sir, if there is any abutment or encasement of the vessel, sir.
Okay.
Sir, here I am not able to see the SMB properly.
How much of the circumference involved you are seeing? Okay.
More than 180. It seems like
distortion of the vessel, any thrombosis, all this is what you see, no?
Sir.
You see if it is there or not. That's what. Just tell and finish it up.
Sir, SMB appears to be encased, sir, in this case, or involved. Sir.
Is it encasement?
More than 180? It's almost complete.
It's almost, sir, 180, more than 80.
Okay. Distorted?
Distorted.
Any thrombus?
Tumor thrombus, sir. Can't make out, sir, in this.
We go above. Okay, SMA?
SMA, sir. Somebody else is controlling. Yeah.
That's okay. You have to see that phase. That's why he's bringing you to the phase.
Yeah.
Okay. Yeah, come down.
It's the celiac.
Same vessel starting below the neck of the pancreas.
This is the SMS.
Yeah, see what is it infiltrated or involved or free? Go down. See.
It is trapeus free, sir.
Yeah, okay.
Trapeus free, sir.
Okay. IVC?
Yeah.
Okay. What about the MPD? Can you comment on the MPD? Earlier you said you don't know about the MPD status. Can you comment on this now?
MPD, sir, appears dilated, sir.
Yeah. Okay. Okay. Fine. Any notes?
Amit, you must come up with these points quickly.
Yes, sir.
Standard way of interpreting a CT.
There are no, sir. There are no parietic notes as such. I can't note parietic notes.
Parietic notes are the only one you'll comment on.
Sir. And CHA, sir.
What are the regional notes that you are looking at?
Sir, CHA, level HDL notes and retropancreatic notes, sir.
Just stop there. Is there a note behind the portal vein? Scroll down a bit inferiorly.
There.
Stop there. What is that between the portal vein and IVC?
Yeah, this might be, sir. There is an enhancement. This might be as a node, sir. Yeah. So this might be a retroportal node.
That's a node. Okay. So there.
Yeah.
Okay, no ascites. No.
There is no evidence. Ascites, no omental caking is there.
So just quickly summarize your CT findings and tell what it is.
So CT in this case depicts bilateral IHBR with the head mass.
Okay.
Bilateral IHBR with the CVD being dilated with along with MPD, and a distal lesion in the head of pancreas involving the SMB, but sparing the SMSL, without any evidence of metastasis. I can note so.
Lymph nodes, local.
Without any locoregional lymphadenopathy, or with locoregional lymphadenopathy involving periportal lymph node, and without any distant lymph nodes or metastatic lesions, deposits.
Okay.
Oh, you can you think your mind can work about the high level of the 1000, more than 1000 CA99, 5 kg weight loss in a month? Why do you think within 1 month all these things might have happened?
In 1 month, sir, most likely maybe due to anorexia related to malignancy, and due to jaundice, which decreases the appetite of the patient. So patient might be
Jaundice within 1 month will not cause 5 kg
5
weight.
kilos loss.
Then
So sudden decrease in weight loss might lead to the suspicion of metastasis, sir, because CA99 is also raised.
you are not eligible.
Advanced disease.
Okay, what is your plan now? Because
Yeah.
you are
Yeah. How do you classify this now? You have the certain pancreatic malignancies. So how do you classify this as?
Sir, this is a case of locally advanced C-head of pancreas, sir, involving the portal vein. So
I say it's a borderline resectable. How do you define borderline resectable tumor?
so borderline resectable involves less than 180 degree of SMA artery SMA involvement, and
Here SMA is free.
SMA is free, sir.
Yeah. So that doesn't come. SMV.
SMB, sir, if there is reconstructable portal vein anatomy in this case, so it can be considered as borderline resectable, sir. If a short segment portal vein is involved and we can reconstruct the vein, sir,
You are not
borderline resectable.
this case. Is it portal vein is looking normal? Dr. Partha told me to see the confluence. Above the confluence, you see that portal vein looks like normal, except there is a periportal lymph node. Whatever is length of the SMB involvement important?
Yes, sir. SMV involvement is there, so I would consider this as a case of locally advanced C-head pancreas.
No, involvement is not enough. No, you have to describe what is the length. Is it only abutment? Is there thrombus associated with it? What tributaries of SMV are also involved? All these things will matter when you are trying to take a surgical decision. No, involvement can mean many things. No, it can be very simple, and then it can be all these things. First jejunal branch involvement,
First
thrombus.
jejunal. Yes, sir. Here it. I'll just like it. I can't make out the first jejunal, sir. Here. And it is a significant length of SMB is involved, sir.
You can't see the first jejunal branch here.
Pardon, sir?
The first jejunal branch just went by.
Yeah.
This one, sir?
Okay, we'll simplify the question. Will you be able to resect this tumor, or will you not be able to resect this tumor?
Sir, we will not be able to resect this tumor, sir.
Reason?
Reason being, it is involving the SMB distal to the confluence, and seems like the first jejunal might be involved in this case. First jejunal might be involved in this case. Not sure.
Okay. Yeah.
Can also modify that there are so many things nowadays that I would like to do this particular thing and then try to be more specific, then take my decision whether we have to do surgery first or we have to give some sort of treatment. So many literature today. So I think Dr. Partha, you can ask some relevant question and we can close because we are already 9:05. 3-4 minutes more we can.
What will you do for this patient? What is the plan?
I would like to have a multidisciplinary team discussion regarding this patient and start this patient because this patient is having a good performance status. So would like to give a course of FOLFIRINOX prior to taking off a surgery and review this patient with
You don't
imaging
want
later.
biopsy? You don't want biopsy for this patient?
I would need biopsy. I would do a US guided biopsy in this case prior
Okay.
to proceeding.
I think the biopsy has come as adenocarcinoma, I think so. Okay. Yeah. Shall we now? I think it's already 9:05.
Directly start chemotherapy or you do something prior to that?
Pardon, sir?
You'll directly start chemotherapy or do something prior to that?
We'll train the prior to starting chemotherapy. I would like to train the bile of this patient. I would like to do ERCP, sir, and train the patients.
Same what point Dr. Partha is making. You have to, again I'm repeating, please think before you speak. You should have a plan in the mind. So once you are saying something, you said I will start chemo, then Dr. Venkat said, will you do biopsy? Then you said, okay, I will do. So my way of looking at it, I will go to the radiology department, try to see different ways of these recon pictures, try to assess about the length of the involvement, all those important points that we have given, because assembly involvement is much more dangerous than the portal vein, because it goes down. If it goes down, goes beyond the jejunal first branch, then the size becomes lesser, smaller and smaller, and then there is a mismatch. All those points are very important. Then you do a FNA, US guided, then you biopsies, then you plan according to, as you said, multidisciplinary approach is not that you just say and everything is finished. You have to decide that this patient will go to multidisciplinary. We have planning in this, we have planned something, then only we are going to operate. So my simple question would be, would you like to do staging laparoscopy when before the section, after doing this thing? So how will you assess after chemotherapy?
Sir, I would like to have the review imaging of this patient prior to taking off a surgery, and I would like.
We have to just wrap up now and take comments and then close the session.
Sir, I would like to have a staging prior to taking up the patient for surgery, if the patient is having a good response to chemotherapy, sir.
Dr. Partha, any other relevant query or Dr. Venkat, then we have to.
If you're planning neoadjuvant therapy, would you want to do a PET scan before that? Is there a role for it?
Yes, sir. PET scan in this case would help. It would like to rule out distant metastasis because the patient is already having a locally advanced disease. So, along with the high CA99 value, so I would like to consider a PET scan prior to proceeding with the chemotherapy, sir.
Partha, can we ask Pradeep sir to open the further this thing? Any last minute?
Yes, sir. Pradeep sir, I think running time, sir.
Oh, so whatever comment you are summarized, Dr. Partha, Dr. Venkat, about him.
Yeah.
I think more clarity on this. Actually, very simple case. You should have more clarity on the history and management. It's a very straightforward case to say. You should not be struggling in very basic things. This case.
Same thing. Imaging also, it should be clear what you want to know, and I think you should have don't waste so much time on that. In the exam, you will not get so much time to discuss about the imaging. Okay.
My comment would be that you have to learn to clinically correlate the things more and more discussions, and that's why you should be able to correlate clinical medicine with the whatever you are seeing at the investigation. So why I was asking, it means that this patient had started jaundice later, maybe pancreatic tumor towards the ancientity started and it started growing. That's why he had so much up by the time he's presenting only 1 month history and 5 kg weight loss, and then so no, a tumor is such a big tumor which is involving SME. So these things should come in our mind, and I would suggest that you should also, Dr. Baker said, go to the radiology department and try to discuss. And when you are preparing the case, you must thoroughly analyze and make your points. These are the points I am making when I am making my first diagnosis. With this, I request open the other faculty, senior faculty member, whoever is present there to give their comments. Then we can close this.
I think, Amit, I think there's a lot of scope for improvement. I think reading CT it's a straightforward case, as Partha rightly said. It's a straightforward case. Actually, in a straightforward case, if you commit any of the mistakes, there won't be an excuse. So you should, your reading of the CT was not up to the mark, because so every time Dr. Reddy has to keep asking you what is next, what is next. So it should come as a flow. See, you are going to become a specialist and you're going to give your opinion, right? So there should be the way you answer the question should be confident and should not be a scope for multiple questions. You are wasting time, right? In the exam, as Dr. Reddy has said, you'll have not much of time. You should be crisp and clear to the point. If you do not know, say so. That's the easiest way to go for the next question, because you have to, time management is very important in the exam. So I think we'll ask other faculty. Dr. Kapoor is there, Professor Jaswant is there. Kapoor, sir.
Morning. Good morning, Pradeep.
Good morning, sir.
Good morning.
So just a few general points. When you describe negative history, you should give symptoms in groups. So for example, when you want to say there is no gastric outlet obstruction, you should say there is no early satiety, there is no postprandial fullness, there is no nausea, there is no frank vomiting, which could be bilious or non-bilious. So all these symptoms should be clubbed into one group and in sequence. When you want to say no cholangitis, you should say no high-grade fever with chills and rigors. Metastatic history, hemoptysis is not a common manifestation of pulmonary metastasis. It's a very rare manifestation. The common manifestation of a pulmonary metastasis is irritating dry cough. The more common symptom is because of malignant pleural effusion, which causes dull, diffuse, low bilateral or unilateral chest pain with dyspnea on exertion. Similarly, many students say there is no history of convulsions to indicate that there is nothing to suggest brain metastasis. Convulsions occur at a very late stage. It starts with recent onset, persistent, moderate to severe headache, followed by visual disturbance, altered sensorium, and convulsions. Differential diagnosis of surgical obstruction. In fact, I would start by jaundice. Of jaundice, if you have a 1 month history of painless progressive jaundice with pruritus and low-grade fever, it could still be hepatitis, theoretically, but is unlike, and with significant weight loss, 5 kg weight loss in a month. All this is possible in hepatitis, but so you should not exclude it, but at the same time, you should not diagnose it. You should say it's a possibility, but this looks more like a surgical obstructive jaundice. And very easy to rule it out would be by LFT and ultrasound. Then comes malignant obstructive jaundice. If it is painless malignant obstructive jaundice, it is more likely to be periampullary, hilar cholangio, or GBC neck. Now, out of these, which you put first would depend on several factors. Obviously, if you are dealing with a patient from north, northeast versus south, that changes the order of priority, because gallbladder would come at the top if the patient is coming from a high incidence area. There are some subtle points which may point towards one of these. For example, some texts mention, although I am not sure whether it is correct or not, that if pruritus precedes jaundice, it is more likely to be cholangiocarcinoma. If the patient has previous history to suggest gallstone disease, biliary colics, or previous history of biliary pain, then you can say that GBC neck is more likely, although that may not be present in all cases. If there is history of a GI bleed, as you said, with a silvery stool in a jaundiced patient, then not all periampullary, only papillary and periduodenal periampullary carcinoma is more likely, because an ampullary carcinoma or a lower end cholangiocarcinoma will not give rise to GI bleed. On examination, the fact that GB is not palpable, if it is palpable, it is distended, because normal GB is not palpable. If it is not palpable, it doesn't mean that it is not distended. The point which Dr. Yadav was asking you, that does it correlate with the build of the patient, the BMI, the fact that the patient is obese? Because if the patient is obese or has a lot of fat, or is a young man with a muscular wall, even a distended gallbladder may not be palpable. So you have to differentiate between a distended gallbladder and a palpable gallbladder. Similarly, a palpable liver is not necessarily enlarged. In a patient with chronic obstructive disease, the diaphragm comes down, pushes the liver down. So liver is palpable, but it is not enlarged because the span is normal. Lastly, the issue of vascular involvement. All MCH students should be familiar with the terms, and they should use these terms when describing vascular involvement, say in esophagus or in pancreas. First thing you have to see is whether there is a fat plane between the vessel and the tumor. If there is a fat plane, the vessel is obviously not involved. But absence of fat plane does not mean that the vessel is involved, because if it is a thin-built patient, a patient who has recently lost significant weight, there is no fat at all. So you have to look at the BMI of the patient. You have to look at how much subcutaneous fat is there, either clinically or in the imaging, how much of fomental fat is there, and then say whether this loss of fat plane is significant or not. If there is no loss, if there is no fat plane between the vessel and the tumor, then you have to describe the angle of contact. Less than 90, 90 to 180, more than 180. And you have to use terms like abutment. You have to use terms like encasement. You have to say whether the shape of the vessel is altered. Normally, these vessels are round or oval, whether there's an alteration of shape, whether there is a change in size. Now, suppose the superior mesenteric vein below and the portal vein above are 10 millimeter or 8 millimeter, and here it is 6 millimeter. So there is a change in size. That again indicates involvement of this segment of the vein. Then you can have complete encasement, which means the vessel is not seen at all in a segment inside the tumor, and a thrombus in a vessel which is seen. So you have to use these terms and you have to look for all these findings and then say. As far as venous involvement in pancreatic head cancer is concerned, when you are asked about what is borderline or is it borderline, you should have said there are several definitions of borderline resectable pancreatic cancer, and they are obviously, because there are several, they differ with each other. And you have to say that which classification of borderline resectable pancreatic cancer you are using, and according to that, whether it is resectable, borderline resectable, locally advanced, or metastatic. When Dr. Partha asked you what are the classifications or what are the types of pancreatic tumor, you should have mentioned all these 4 terms in the first go, and then said, in this case, in which group this patient fits. So students, if you want to read more about borderline resectable pancreatic cancer, Dr. Kailash Kurdia from AIIMS, New Delhi, along with me, he had written a very beautiful review article on various definitions of borderline resectable pancreatic cancer. Please send me a mail, bkkapoor.india@gmail.com. Write BRPC in the subject of the mail. I'll send you that article. Thank you. Thank you, Pradeep.
Thank you. Thank you, sir. Jaswant, any comment?
So good morning, sir. It's regarding the obstructive jaundice and renal failure. Even though there are many causes, dehydration is one of the most important factors. Because of malignancy and jaundice, patient may not take adequate intake. And because of various investigation, we may make the patient fast, overnight fasting and all. More than that, the bile salt will act as a diuretic. If we observe, patient will keep on passing large amount of urine. That will cause dehydration. Suddenly they will stop passing urine and all. So dehydration is the most important factor. So we titrate the patient before surgery, during surgery, post-operative also. Unless we take this factor into account, we'll miss the bus. The dehydration is one of the important factors. Please keep in mind. That's all, sir. Thank you.
If there are no more comments, can we wind up Professor Yadav, Partha, and Venkatrami Reddy?
Yes, sir.
Yes. Okay. Thank you, Amit, and thank you, Venkatrami Reddy, TD Yadav, and Parthasarathy and other faculty. Thank you.
Thank you, sir.